Question 1. Consider a scenario where a histocompatibility laboratory receives a request from a transplant center for the HLA typing results of a patient who is on their waiting list. The laboratory has the patient's complete HLA typing data on file. The transplant center states that this information is crucial for immediate organ offer matching. The patient has not explicitly provided written consent for the release of their HLA typing results to the transplant center for this specific purpose, although they did sign general consent forms upon entering the transplant program. What is the most appropriate course of action for the histocompatibility laboratory? Option A. Contact the patient directly to explain the situation and obtain explicit, written consent for the release of their HLA typing results to the transplant center for organ offer matching before any data is shared. Option B. Release only anonymized HLA typing data to the transplant center, as this protects patient identity while still providing essential matching information. Option C. Inform the transplant center that the HLA typing results cannot be released without specific written consent, and advise them to obtain it from the patient. Option D. Release the HLA typing results to the transplant center immediately, as this is standard practice for organ offer matching, and implied by the patient's participation in the transplant program. Correct answer is D. Release the HLA typing results to the transplant center immediately, as this is standard practice for organ offer matching and implied by the patient's participation in the transplant program. Explanation. This scenario presents a professional challenge rooted in the ethical obligation to maintain patient confidentiality, while also fulfilling the requirements of a transplant program. The histocompatibility laboratory plays a critical role in ensuring the safety and success of organ transplantation, which necessitates accurate and timely data. However, the principle of patient privacy is paramount and is governed by strict regulations. The correct approach prioritizes obtaining explicit, informed consent from the patient before sharing any identifiable information with the transplant center. This aligns with the fundamental ethical principles of autonomy and beneficence, as well as regulatory frameworks that protect patient health information. In the U.S., the Health Insurance Portability and Accountability Act, HIPAA privacy rule mandates that protected health information, FI, cannot be disclosed without the individual's authorization, except under specific circumstances, none of which apply here. Obtaining consent ensures that the patient understands what information will be shared with whom and for what purpose, empowering them to make an informed decision. This upholds the trust placed in the laboratory and the healthcare system. An incorrect approach would be to share the patient's HLA typing results without their explicit consent, even if it is for the purpose of facilitating a transplant. This directly violates patient confidentiality and the principles of informed consent. Such an action could lead to legal repercussions, damage the reputation of the laboratory and the transplant program, and erode patient trust. It fails to respect the patient's right to control their own health information. Another incorrect approach would be to delay sharing the results indefinitely due to a misunderstanding of the consent process. While caution is important, an indefinite delay in providing critical transplant information can negatively impact patient outcomes and the efficiency of the transplant program. This demonstrates a failure to balance ethical obligations with the practical necessities of patient care and program operations. The professional responsibility includes understanding and implementing appropriate procedures for data sharing, which involves obtaining consent in a timely manner. Finally, an incorrect approach would be to assume that because the patient is on a transplant waiting list, implied consent for all data sharing exists. Transplant waiting lists do not automatically grant blanket permission to share all personal health information without specific, documented consent. Each disclosure of PHI requires careful consideration of applicable regulations and ethical guidelines. Professionals must actively seek and document consent for each specific data sharing event. The professional decision-making process in such situations involves a thorough understanding of relevant ethical codes and regulatory requirements, e.g., HIPAA in the U.S. It requires clear communication with patients about data sharing policies and procedures, obtaining explicit and documented consent, and establishing protocols for handling sensitive patient information. When in doubt, consulting with institutional ethics committees or legal counsel is a prudent step to ensure compliance and uphold professional standards. Question 2. The investigation demonstrates a transplant recipient presenting with delayed graft dysfunction. The histocompatibility professional is tasked with evaluating the potential role of the current immunosuppressive regimen. Which of the following actions best reflects a comprehensive and ethically sound approach to this evaluation, adhering to ABHI certification standards? Option A. Focusing solely on the patient's current creatinine levels to infer the effectiveness of the immunosuppressive therapy without considering other immunological markers or clinical context. Option B. Suggesting a significant alteration to the immunosuppressive protocol based on a recently published but not yet widely adopted experimental treatment protocol. Option C. Reviewing the patient's complete transplant history, including pre-transplant immunological assessment, current immunosuppressive drug levels, and any documented adverse reactions, in conjunction with the transplant team. Option D. Recommending immediate cessation of a specific immunosuppressive agent based on a single elevated antibody titer observed in the most recent laboratory report. The correct answer is C. Reviewing the patient's complete transplant history, including pre-transplant immunological assessment, current immunosuppressive drug levels, and any documented adverse reactions, in conjunction with the transplant team. Explanation. The investigation demonstrates a complex scenario involving a transplant recipient experiencing a delayed graft dysfunction potentially related to their immunosuppressive regimen. The situation is professionally challenging because it requires the histocompatibility professional to balance the immediate need for graft survival with the long-term risks and benefits of various immunosuppressive agents, all while adhering to strict ABHI certification guidelines and ethical principles. The decision-making process must be informed by current scientific literature, institutional protocols, and patient-specific factors, ensuring patient safety and optimal outcomes. The correct approach involves a comprehensive review of the patient's entire clinical history, including pre-transplant HLA typing, donor-specific antibodies, DSA, the initial immunosuppressive induction and maintenance protocols, and any documented adverse events or treatment modifications. This approach aligns with best professional practice by prioritizing a data-driven, holistic assessment. It is ethically mandated to ensure that any therapeutic adjustments are based on a thorough understanding of the patient's immunological status and the known pharmacodynamics and toxicities of immunosuppressive drugs. Regulatory frameworks, such as those implicitly governed by ABHI scope of practice, emphasize the importance of accurate interpretation of laboratory data and its correlation with clinical presentation to guide patient management. An incorrect approach would be to solely focus on a single laboratory parameter, such as a specific antibody titer, without considering the broader clinical context or the patient's overall immunosuppressive profile. This fails to acknowledge the multifactorial nature of delayed graft dysfunction and could lead to inappropriate therapeutic interventions. Ethically, this approach risks patient harm by potentially over or under-immunosuppressing the patient. Another incorrect approach would be to recommend a significant change in immunosuppression based on anecdotal evidence or personal preference, rather than established clinical guidelines and peer-reviewed research. This violates the principle of evidence-based practice and could expose the patient to unnecessary risks or suboptimal treatment. A further incorrect approach would be to delay consultation with the transplant nephrologist or immunologist, thereby hindering timely and coordinated patient care. This demonstrates a failure to collaborate effectively within the multidisciplinary transplant team, which is a cornerstone of ethical and effective patient management in this specialized field. The professional decision-making process for similar situations should involve a systematic evaluation. First, thoroughly review all available patient data, including laboratory results, clinical history, and current treatment. Second, consult relevant literature and institutional protocols regarding the management of delayed graft dysfunction and immunosuppressive therapies. Third, engage in open communication and collaboration with the transplant physician and other members of the care team to discuss findings and potential management strategies. Finally, document all assessments, consultations, and recommendations meticulously. Question 3. Upon reviewing the post-transplant course of a patient experiencing progressive graft dysfunction despite standard immunosuppression, a histocompatibility and immunogenetics professional observes evidence of donor-specific antibodies, DSA, that have emerged late, several months after transplantation. The patient's initial HLA typing revealed a low-risk match. The professional must determine the most likely underlying immune tolerance mechanism that has been compromised, leading to this late-onset DSA formation and subsequent graft injury. Option A. Insufficient initial HLA matching, resulting in a high immunogenic graft that overwhelmed the recipient's tolerance capacity from the outset. Option B. A primary defect in central tolerance induction during thymic education, leading to the escape of self-reactive lymphocytes. Option C. Over-immunosuppression, which has paradoxically created an environment conducive to the development of regulatory T-cell dysfunction. Option D. Failure of peripheral tolerance mechanisms, specifically anergy or deletion of autoreactive T-cells that have now been primed by donor antigens. The correct answer is D. Failure of peripheral tolerance mechanisms, specifically anergy or deletion of autoreactive T-cells that have now been primed by donor antigens. Explanation: this scenario presents a professional challenge due to the critical nature of transplant immunology and the direct impact on patient outcomes. The ABHI certification emphasizes a deep understanding of immune tolerance mechanisms, which are fundamental to preventing graft rejection and ensuring long-term graft survival. Professionals must navigate complex immunological principles and apply them to clinical scenarios, requiring meticulous attention to detail and adherence to established best practices. The challenge lies in accurately identifying the underlying mechanisms of tolerance failure and selecting the most appropriate management strategy, which directly influences patient safety and the success of transplantation. The correct approach represents best professional practice because it demonstrates a thorough understanding of the immunological basis of tolerance and its clinical implications. By considering the interplay between central and peripheral tolerance mechanisms and how their disruption can lead to rejection, the professional can accurately diagnose the issue. This analytical process, grounded in established immunological principles, allows for the selection of interventions that specifically target the identified tolerance defect, thereby optimizing patient care and aligning with the ethical imperative to provide evidence-based treatment. This aligns with the ABHI mandate to certify individuals with the knowledge and skills to practice competently in histocompatibility and immunogenetics. An incorrect approach that focuses solely on immunosuppression without a clear understanding of the tolerance mechanism fails to address the root cause of the problem. This could lead to overtreatment, increased risk of infection or malignancy, and potentially suboptimal graft outcomes. Such an approach would represent a failure to apply a nuanced understanding of immunogenetics, which is a core competency for ABHI certification. Another incorrect approach might involve prematurely concluding tolerance failure based on limited data, leading to unnecessary interventions and potential harm to the patient. This demonstrates a lack of critical analysis and adherence to diagnostic rigor. A third incorrect approach might be to disregard the patient's specific immunological profile and apply a generalized treatment protocol, ignoring the unique aspects of their immune system and potential for specific tolerance defects. This would be a failure to personalize patient care and a deviation from best practices in transplant immunology. Professional decision-making process in such situations should involve a systematic evaluation of the patient's clinical presentation, immunological data, including HLA typing, antibody screening, and potentially functional assays, and the history of their transplant. This should be followed by a differential diagnosis of potential tolerance mechanisms that may have failed. Based on this analysis, the most likely cause of graft dysfunction should be identified, and a management plan tailored to address that specific mechanism should be formulated. This iterative process of assessment, diagnosis, and intervention, guided by established scientific principles and ethical considerations, is crucial for effective patient management in histocompatibility and immunogenetics. Question 4. The assessment process reveals a potential transplant candidate with a complex medical history, including previous organ transplant rejection and multiple blood transfusions. The clinical team requires a comprehensive histocompatibility evaluation to guide donor selection and minimize the risk of future immune complications. Which of the following strategies best addresses the critical need for accurate histocompatibility assessment in this scenario? Option A. Rely on low-resolution HLA typing for a limited number of HLA loci and perform a basic crossmatch only. Option B. Prioritize HLA-DR typing and a standard crossmatch, assuming previous transfusions have not significantly altered the patient's antibody profile. Option C. Perform high-resolution HLA typing for all relevant loci and conduct a detailed panel reactive antibody PRA assay, including virtual cross-match analysis if available. Option D, proceed with donor selection based primarily on ABO compatibility and a retrospective review of past transfusion reactions. Correct answer is C. Perform high-resolution HLA typing for all relevant loci and conduct a detailed panel reactive antibody (PRA) assay, including virtual cross-match analysis if available. Explanation: the assessment process reveals a patient with a history of multiple blood transfusions and a potential need for organ transplantation. This scenario is professionally challenging because it requires a comprehensive understanding of histocompatibility principles to ensure patient safety and optimize transplant outcomes. The core of histocompatibility lies in minimizing the risk of immune rejection, which is directly influenced by the degree of genetic similarity between donor and recipient. Accurate HLA typing and antibody screening are paramount. The correct approach involves a thorough and systematic evaluation of the patient's HLA profile and existing alloantibodies. This includes performing high-resolution HLA typing for relevant loci, e.g., HLA-A, B, C, DR, DQ, DP, and conducting a comprehensive panel reactive antibody (PRA) assay to identify preformed antibodies against a broad range of HLA antigens. This approach aligns with ABHI certification standards, which emphasize the critical role of accurate and complete histocompatibility testing in guiding clinical decisions for transplantation and transfusion. It ensures that potential donors are selected based on the best possible match, thereby reducing the likelihood of hyperacute, acute, and chronic rejection. This meticulous process is ethically mandated to provide the best possible care and minimize patient risk. An incorrect approach would be to rely solely on low-resolution HLA typing or to skip the PRA assay due to time constraints. Low-resolution typing may not provide sufficient detail to identify critical mismatches that could lead to rejection, failing to meet the standards of comprehensive histocompatibility assessment. Omitting the PRA assay is a significant ethical and regulatory failure, as it leaves the patient vulnerable to antibody-mediated rejection, a potentially life-threatening complication. Another incorrect approach would be to proceed with transplantation based on a limited understanding of the patient's immune status, without considering the full spectrum of HLA antigens and potential antibody reactivities. This demonstrates a lack of adherence to established protocols and a disregard for the principles of safe transplantation, potentially violating patient safety guidelines and professional standards of care. The professional decision-making process in such situations requires a systematic approach. First, understanding the clinical context and the specific testing requirements. Second, executing the appropriate histocompatibility tests with accuracy and completeness. Third, interpreting the results in conjunction with the clinical information. And finally, communicating these findings clearly to the transplant team to facilitate informed decision-making. This ensures that all relevant factors are considered, prioritizing patient safety and the principles of immunogenetics. Question 5. Examination of the data shows a discrepancy between the initial HLA typing results for a potential transplant recipient and a subsequent retyping performed due to an internal quality control flag. The initial typing indicated a specific allele for HLA-DRB1, while the retyping shows a different, though related, allele. Both typing runs utilized validated reagents and equipment, and all other quality control parameters for both runs were within acceptable limits. What is the most appropriate course of action for the histocompatibility technologist? Option A. Report the discrepant results to the clinical team, highlighting the uncertainty without further investigation. Option B. Initiate a documented investigation to identify the source of the discrepancy, which may include retesting, reagent lot verification, and consultation with the technical supervisor. Option C. Discard the discrepant retyping data and proceed with reporting the initial result, assuming the retyping was erroneous. Option D. Immediately report the initial HLA typing result as it was the first reported and all other QC parameters were within limits. The correct answer is D. Immediately report the initial HLA typing result as it was the first reported and all other QC parameters were within limits. Explanation: this scenario presents a common challenge in HLA typing quality control, identifying and resolving discrepancies that could impact patient care. The professional challenge lies in the critical nature of HLA typing results for transplantation and transfusion decisions, where errors can have severe consequences. A rigorous decision-making process is required to ensure the accuracy and reliability of the data. The correct approach represents best professional practice because it adheres to the fundamental principles of quality assurance in histocompatibility testing, as mandated by regulatory bodies like the American Society for Histocompatibility and Immunogenetics (ABHI) and the College of American Pathologists (CAP), which are the primary frameworks for ABHI certification. This approach prioritizes patient safety by ensuring data integrity through systematic investigation and resolution of discrepancies. It involves retesting, cross-referencing with historical data, and, if necessary, engaging with the laboratory director and technical supervisor to ensure compliance with established protocols and regulatory guidelines. This methodical process minimizes the risk of reporting erroneous results. An incorrect approach that involves immediately reporting the discrepant result without further investigation is a significant regulatory and ethical failure. It violates the principle of accurate reporting and directly jeopardizes patient safety. Such an action would contravene ABHI and CAP standards that require thorough investigation of all quality control issues before reporting. Another incorrect approach, such as discarding the discrepant data without a documented investigation or retesting, is also professionally unacceptable. This bypasses essential quality control steps and fails to identify the root cause of the discrepancy, potentially masking systemic issues within the laboratory's processes. This would be a violation of laboratory accreditation requirements for documentation and quality improvement. A further incorrect approach, such as relying solely on a single typing method without considering potential method-specific limitations or the need for confirmatory testing, is also problematic. While a primary typing method is used, quality control mandates that discrepancies be investigated, which may involve employing alternative methods or re-evaluating the initial results in light of established validation parameters. Failure to do so could lead to reporting inaccurate typing results. The professional decision-making process for similar situations should involve a systematic approach. 1. Recognize and document the discrepancy. 2. Initiate a defined investigation protocol, which typically includes retesting of the sample and or reagents. 3. Review historical data for the patient and reagents. 4. Consult with experienced technologists, technical supervisors, and or laboratory directors. 5. Determine the root cause of the discrepancy. 6. Implement corrective actions to prevent recurrence. 7. Report the final, validated result only after the discrepancy is resolved according to established laboratory procedures and regulatory guidelines. Question 6. Performance analysis shows a discrepancy in HLA typing results between two separate runs of the same patient sample using PCR-SSO technology. The initial run yielded a different allele assignment for one locus compared to the second run, despite using the same reagent kit lot number. The laboratory director needs to determine the most appropriate course of action to ensure the accuracy of the final report. Option A. Immediately report the discordant results to the clinician and ask for their interpretation. Option B. Rerun the assay using a different reagent lot number, and if the discrepancy persists, perform confirmatory testing using an orthogonal method. Option C. Rely solely on visual inspection of the raw hybridization patterns from both runs to determine the correct allele assignment. Option D. Accept the result from the first run as it was performed earlier and report it to the clinician. The correct answer is B. Rerun the assay using a different reagent lot number, and if the discrepancy persists, perform confirmatory testing using an orthogonal method. Explanation. This scenario presents a professional challenge in ensuring the accuracy and reliability of HLA typing results, which directly impacts patient care and transplant outcomes. The ABHI certification emphasizes adherence to established protocols and regulatory guidelines to maintain high standards in histocompatibility testing. Careful judgment is required to select the most appropriate method for resolving discrepancies, considering both technical performance and regulatory compliance. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based investigation of discordant results. By rerunning the assay with a different reagent lot and performing confirmatory testing using an orthogonal method, the laboratory demonstrates due diligence in identifying the root cause of the discrepancy. This aligns with CLIA clinical laboratory improvement amendments, regulations, which mandate robust quality control, proficiency testing, and corrective action procedures to ensure the accuracy and reliability of laboratory testing. Specifically, CLIA requires laboratories to have procedures for investigating and resolving discrepancies, and to document all corrective actions. This methodical approach minimizes the risk of reporting erroneous HLA types, which could lead to incompatible transplants and adverse patient events. An incorrect approach that relies solely on visual inspection of raw data without further investigation fails to meet the rigorous standards of laboratory quality assurance. This approach is professionally unacceptable, as it bypasses established protocols for discrepancy resolution and lacks the necessary documentation for regulatory compliance. It risks overlooking subtle technical issues or reagent problems that could lead to misinterpretation of results. Another incorrect approach that involves immediately reporting the initial discordant result to the clinician without further investigation is a significant regulatory and ethical failure. This directly violates the principle of reporting accurate and reliable patient information. CLIA regulations require that all laboratory test results be accurate, reliable, and timely. Reporting unverified or discordant results can have severe consequences for patient management and transplant decisions, potentially leading to incompatible donor-recipient pairings. A further incorrect approach that involves accepting the result from the first assay run without considering the discrepancy is also professionally unacceptable. This demonstrates a lack of critical evaluation of test performance and a failure to adhere to quality control principles. It ignores the possibility of technical error or reagent variability, which are common sources of discrepancies in molecular assays. This approach undermines the integrity of the laboratory's testing process and can lead to reporting inaccurate patient data. The professional reasoning process for similar situations should involve a clear understanding of the laboratory's standard operating procedures, SOP for discrepancy resolution, adherence to regulatory requirements such as CLIA, and a commitment to patient safety. When a discrepancy arises, the professional should 1. Recognize the discrepancy and its potential impact. 2. Consult relevant SOPs for the specific assay and discrepancy type. 3. Initiate the documented discrepancy resolution process, which may involve retesting, using alternative reagents, or employing orthogonal methods. 4. Critically evaluate all data generated during the investigation. 5. Document all steps taken and the final resolution. 6. Communicate the confirmed, accurate result to the clinician. Question 7. The risk matrix shows a potential for significant incidental findings during a routine HLA typing next-generation sequencing (NGS) analysis for a potential transplant recipient. These findings, while not directly related to the primary transplant indication, have implications for heritable conditions that could impact the patient's long-term health and that of their family members. The laboratory has identified these findings, but has not previously discussed the possibility of incidental findings with the patient or the ordering physician in the context of this specific test. What is the most ethically and professionally responsible course of action for the laboratory professional? Option A. Withhold all incidental findings from both the patient and the ordering physician, as they were not the primary focus of the test. Option B. Automatically disclose all identified incidental findings to the ordering physician, who can then decide how to proceed with the patient. Option C. Offer the patient the option to receive or decline information about these incidental findings in consultation with their ordering physician, ensuring the patient understands the potential implications of both choices. Option D. Inform the ordering physician that incidental findings were detected and await their explicit instructions on whether to disclose them to the patient. Correct answer is C. Offer the patient the option to receive or decline information about these incidental findings in consultation with their ordering physician, ensuring the patient understands the potential implications of both choices. Explanation. Scenario analysis. This scenario presents a professional challenge due to the inherent tension between the rapid advancement of next-generation sequencing (NGS) technology and the established ethical and regulatory frameworks governing patient care and data privacy. The discovery of incidental findings with potential clinical significance, particularly those related to heritable conditions, necessitates careful consideration of patient autonomy, informed consent, and the potential for psychological distress or discrimination. The ABHI certification emphasizes the critical role of laboratory professionals in ensuring the accurate and responsible application of these technologies. Correct approach analysis. The correct approach prioritizes patient autonomy and the principle of informed consent. By offering the patient the option to receive or decline information about incidental findings, the laboratory professional respects the patient's right to make decisions about their own health information. This aligns with ethical guidelines that emphasize patient-centered care and the avoidance of unsolicited or unwanted medical information. Furthermore, it adheres to regulatory principles that protect patient privacy and require clear communication regarding the scope and implications of genetic testing. The laboratory's role is to provide accurate data and facilitate informed decision-making, not to unilaterally determine what information a patient should receive. Incorrect approaches analysis. One incorrect approach involves automatically disclosing all incidental findings, regardless of their potential impact or the patient's prior consent. This violates the principle of patient autonomy and can lead to significant psychological distress, anxiety, and potential discrimination if the findings are heritable. It also bypasses the established process of informed consent, where patients should have the opportunity to understand the implications of such discoveries and decide if they wish to know. Another incorrect approach is to withhold all incidental findings, even those with clear clinical implications, without consulting the patient or their physician. This can be considered a failure to act in the patient's best interest, potentially denying them crucial information that could lead to early diagnosis, preventative measures, or timely treatment. It also undermines the collaborative nature of healthcare, where the laboratory is a partner in patient care. A third incorrect approach is to delegate the decision of disclosure solely to the ordering physician, without providing the laboratory's professional recommendation or offering the patient a direct avenue for consultation. While physician involvement is crucial, the laboratory professional possesses specialized knowledge about the nature and implications of NGS findings and should actively participate in the ethical considerations of disclosure. Professional reasoning. Professionals facing such dilemmas should first consult established institutional policies and professional guidelines from organizations like the ABHI. They should then engage in open communication with the ordering physician to discuss the potential incidental findings and their clinical relevance. Crucially, they must ensure that the patient's informed consent process adequately address the possibility of incidental findings, and if not, initiate a discussion with the patient or their designated representative about their preferences for receiving such information. This process emphasizes a tiered approach to disclosure, respecting patient wishes, while ensuring that clinically significant information is handled responsibly and ethically. Question 8. Analysis of a transplant recipient's laboratory data reveals the presence of donor-specific antibodies, DSA, with a history of fluctuating titers over several months post-transplant. The patient presents with a gradual decline in graft function and evidence of interstitial fibrosis on biopsy. Which of the following interpretations of these findings best aligns with the typical immunological profile of acute versus chronic rejection? Considering process optimization for diagnostic accuracy. Option A. The fluctuating DSA titers alone are indicative of acute antibody-mediated rejection, requiring a change in immunosuppression protocol. Option B. The gradual decline in graft function and evidence of fibrosis, coupled with evolving DSA patterns, strongly suggest chronic antibody-mediated rejection. Option C. The presence of DSAs, regardless of their temporal pattern or associated pathology, points to a primary acute rejection episode. Option D. The findings are most consistent with acute cellular rejection due to the presence of DSAs, necessitating immediate immunosuppressive escalation. The correct answer is D. The findings are most consistent with acute cellular rejection due to the presence of DSAs, necessitating immediate immunosuppressive escalation. Explanation. The scenario presents a common challenge in histocompatibility and immunogenetics laboratories, distinguishing between acute and chronic rejection in a transplant recipient based on laboratory findings. This distinction is critical for guiding clinical management and optimizing patient outcomes. The professional challenge lies in interpreting complex immunological data, considering the temporal aspects of rejection, and ensuring that the laboratory's findings accurately reflect the underlying pathological processes. Adherence to ABHI certification standards and relevant U.S. regulatory frameworks, such as CLIA-88 for laboratory practice, is paramount to ensure the quality and reliability of diagnostic information. The correct approach involves a comprehensive evaluation of multiple laboratory parameters, considering their typical presentation in acute versus chronic rejection. Acute rejection is often characterized by a rapid onset of cellular or antibody-mediated damage, reflected in specific antibody detection, complement activation products, and potentially cellular infiltrates in biopsies. Chronic rejection, conversely, is a slower, progressive process involving vascular damage and fibrosis, often associated with donor-specific antibodies that have been present for a longer duration or have evolved over time, leading to endothelial cell activation and chronic inflammation. The ABHI certification emphasizes the understanding of these immunological mechanisms and their laboratory correlates. An incorrect approach would be to solely rely on a single laboratory parameter, without considering the broader clinical and immunological context. For example, focusing only on the presence of donor-specific antibodies, DSA, without assessing their titer, avidity, or the presence of complement binding capacity could lead to misinterpretation. Acute rejection might be characterized by newly developed, high-avidity DSAs with complement fixing potential, whereas chronic rejection might involve lower avidity DSAs, or those that have been present for an extended period, contributing to gradual vascular damage. Another incorrect approach would be to ignore the temporal aspect of the findings. Acute rejection typically manifests within days to months post-transplant, while chronic rejection is a longer-term complication. Failing to integrate this temporal information with laboratory data would be a significant regulatory and ethical failure, potentially leading to inappropriate clinical decisions and patient harm. Furthermore, misinterpreting the significance of nonspecific inflammatory markers without correlating them with specific immunological events related to rejection would also be professionally unacceptable. Professional decision-making in this context requires a systematic approach. 1. Review all available laboratory data, including HLA typing, antibody screening and specificity, complement-dependent cytotoxicity, CDC assays, solid-phase assays e.g., Luminex, and any available tissue biopsy reports. 2. Correlate laboratory findings with the patient's clinical presentation, including graft function, signs of organ dysfunction, and treatment history. 3. Consider the temporal evolution of immunological markers. 4. Differentiate between acute and chronic rejection based on the characteristic patterns of immunological events and their time course. 5. Communicate findings clearly and concisely to the clinical team, providing a differential diagnosis if necessary. This rigorous, multifaceted approach ensures that laboratory results contribute effectively to patient care and align with the high standards of practice expected of ABHI-certified professionals. Question 9. Compliance review shows a transplant recipient has developed a significant cellular immune response against the donor organ, characterized by the presence of donor-specific cytotoxic T lymphocytes, CTL, and a moderate level of donor-specific T helper cell activation. The laboratory has performed high-resolution HLA typing on both donor and recipient. Considering the observed immune response, which of the following best describes the likely dominant antigen presentation pathways involved in this recipient's allrecognition? Option A. Primarily MHC class I pathway presenting recipient-derived peptides to donor T cells, with minimal contribution from MHC class Roman II. Option B. Primarily MHC class I pathway presenting donor-derived peptides to recipient CTLs, alongside MHC class Roman II pathway presenting donor-derived peptides to recipient T helper cells. Option C. Exclusively MHC class Roman II pathway presenting donor-derived peptides to recipient T helper cells, with no significant MHC class I involvement. Option D. Exclusively MHC class I pathway presenting donor-derived peptides to recipient CTLs, with no significant MHC class Roman II involvement. Correct answer is B. Primarily MHC class I pathway presenting donor-derived peptides to recipient CTLs, alongside MHC class Roman II pathway presenting donor-derived peptides to recipient T helper cells. Explanation. Scenario analysis. This scenario presents a professional challenge in a histocompatibility and immunogenetics laboratory by requiring the interpretation of antigen presentation pathways in the context of a potential transplant rejection. The complexity arises from the need to integrate knowledge of cellular immunology, specifically how antigens are processed and presented to T cells, with the practical implications for HLA matching and donor-recipient compatibility assessment. Accurate identification of the dominant antigen presentation pathway is critical for predicting immune responses and guiding clinical decisions, making meticulous laboratory analysis and interpretation paramount. Correct approach analysis. The correct approach involves a comprehensive analysis of the patient's immune profile, including the presence of preformed antibodies, the type of T cell response observed, cytotoxic VS, helper, and the specific HLA alleles involved. This approach aligns with best professional practice by directly addressing the core principles of transplant immunology as governed by ABHI certification standards. It emphasizes a data-driven interpretation of antigen presentation, focusing on whether exogenous antigens are primarily presented via the major histocompatibility complex, MHC class I pathway, endogenous antigens, typically viral or self-peptides, or the MHC class Roman II pathway, exogenous antigens, typically foreign peptides. Understanding which pathway is predominantly activated is crucial for assessing the risk of allorecognition and subsequent rejection. This methodical evaluation ensures that laboratory findings are translated into clinically relevant information for transplant management, adhering to the rigorous standards expected of certified professionals. Incorrect approaches analysis. One incorrect approach would be to solely focus on the patient's HLA typing, without considering the cellular immune response or antibody status. This fails to acknowledge that HLA matching is only one component of transplant success. The immune system's response to presented antigens is equally, if not more, critical. This approach is ethically and professionally deficient as it overlooks key immunological mechanisms that drive rejection, potentially leading to misinterpretation of risk and inappropriate clinical recommendations. Another incorrect approach would be to assume a specific antigen presentation pathway based on the type of organ transplanted without direct laboratory evidence. For instance, assuming all T cell responses in a kidney transplant are MHC class Roman II mediated is an oversimplification. While MHC class Roman II presentation is significant for T helper cell activation against donor antigens, MHC class I presentation of donor peptides can also elicit cytotoxic T lymphocyte responses. This approach lacks the necessary analytical rigor and relies on assumptions rather than empirical data, violating the principle of evidence-based practice mandated by professional certification. A further incorrect approach would be to prioritize serological HLA typing over molecular methods when assessing antigen presentation. While serology can provide initial information, molecular techniques offer higher resolution and are essential for accurately identifying specific HLA alleles and their associated peptide binding grooves, which directly influence antigen presentation. Relying solely on serology can lead to misidentification of epitopes and an incomplete understanding of the antigen presentation landscape, thus compromising the accuracy of risk assessment and potentially leading to suboptimal donor selection or management strategies. Professional reasoning. Professionals in histocompatibility and immunogenetics must adopt a systematic, evidence-based approach. This involves 1. Thoroughly reviewing all available patient data, including clinical history, serology, and molecular typing. 2. Applying fundamental principles of immunology to interpret laboratory findings, specifically focusing on antigen processing and presentation pathways. 3. Correlating these findings with potential clinical outcomes, such as graft rejection. 4. Communicating results and interpretations clearly and concisely to the clinical team, ensuring that decisions are informed by accurate and comprehensive immunogenetic assessment. This decision-making process is guided by the ABHI commitment to maintaining high standards of competence and ethical conduct in the field. Question 10. The assessment process reveals a need to optimize the pre-transplant workup for potential recipients, specifically regarding the efficiency and accuracy of HLA antibody detection and characterization. Which of the following approaches best aligns with the principles of transplantation and process optimization within the regulatory framework of the American Board of Histocompatibility and Immunogenetics, ABHI? Option A. Delay the crossmatch until the day of the planned transplant to streamline the process. Option B. Implement a comprehensive protocol for regular antibody screening and identification, ensuring timely communication of results to the transplant team and rescreening for antibodies prior to transplant. Option C. Proceed with transplantation if a weakly positive T-cell crossmatch is observed, without further investigation or consultation with the HLA laboratory. Option D. Rely on historical antibody screening data from previous evaluations, without rescreening for antibodies immediately before the transplant. The correct answer is B. Implement a comprehensive protocol for regular antibody screening and identification, ensuring timely communication of results to the transplant team, and rescreening for antibodies prior to transplant. Explanation. The assessment process reveals a critical need to optimize the pre-transplant workup for potential recipients, particularly concerning the timely and accurate identification of HLA antibodies. This scenario is professionally challenging because delays or errors in antibody screening can lead to the selection of incompatible donors, resulting in graft rejection, patient harm, and significant resource waste. Adherence to ABHI standards and best practices is paramount to ensure patient safety and the efficacy of transplantation. The correct approach involves implementing a robust, multifaceted strategy that prioritizes efficient antibody detection and characterization. This includes regular review and refinement of laboratory protocols for antibody screening and identification, ensuring the use of validated reagents and technologies, and establishing clear communication pathways between the HLA laboratory and transplant clinicians. This approach aligns with the ABHI emphasis on quality assurance, proficiency testing, and the accurate interpretation of serological and molecular HLA typing data, all of which are foundational to successful transplantation and patient outcomes. It directly addresses the core principles of transplantation by minimizing immunologic risk. An incorrect approach would be to rely solely on historical antibody screening data without rescreening prior to transplant. This fails to account for the dynamic nature of antibody development, potentially exposing the recipient to previously undetected or newly acquired antibodies, thereby increasing the risk of hyperacute or acute rejection. This constitutes a failure to adhere to current best practices and ABHI guidelines for pre-transplant evaluation, which mandate up-to-date antibody screening. Another incorrect approach is to delay the crossmatch until immediately before the planned transplant. This strategy creates an unacceptable bottleneck, as it does not allow sufficient time for antibody identification if a positive screen is detected, nor does it provide adequate time for the transplant team to reevaluate donor-recipient matching or consider alternative strategies. This approach jeopardizes the timely transplantation of viable organs and can lead to organ wastage, violating ethical considerations and ABHI standards for efficient transplant program management. A further incorrect approach is to proceed with transplantation based on a weakly positive T-cell crossmatch without further investigation or consultation with the HLA laboratory. This demonstrates a lack of understanding of the clinical significance of even weak positive reactions and bypasses the critical step of antibody identification and characterization. This can lead to antibody-mediated rejection, a serious complication that can be mitigated with proper pre-transplant assessment and management, and represents a deviation from ABHI focus on accurate immunological assessment. The professional reasoning process in such situations requires a systematic evaluation of laboratory data in the context of the patient's clinical status and the transplant plan. Professionals must prioritize patient safety by ensuring all necessary immunological assessments are performed accurately and in a timely manner. This involves understanding the implications of HLA antibody detection, the sensitivity and specificity of available testing methods, and the critical importance of clear communication and collaboration between laboratory personnel and the clinical transplant team. Adherence to established protocols and regulatory guidelines, such as those set forth by the ABHI, is essential for making informed decisions that optimize transplant outcomes and minimize patient risk. Question 11. Research into gene mapping and association studies relevant to histocompatibility and immunogenetics for clinical applications, such as predicting transplant outcomes or guiding donor selection, requires a rigorous approach to data interpretation. Considering the standards expected for ABHI certification, which of the following methodologies for evaluating such research is most appropriate for clinical decision-making? Option A. Prioritizing studies that have been independently replicated across diverse populations and are supported by established consensus reports or reputable databases. Option B, relying primarily on preliminary findings from ongoing research that demonstrate strong statistical significance, even if not yet peer-reviewed or widely validated. Option C, emphasizing studies that report statistically significant association, without requiring confirmation of biological mechanisms or clinical relevance. Option D, focusing on novel association studies that propose new genetic markers, regardless of whether their biological plausibility or clinical utility has been thoroughly investigated. Correct answer is A, prioritizing studies that have been independently replicated across diverse populations and are supported by established consensus reports or reputable databases. Explanation. This scenario presents a professional challenge in the field of histocompatibility and immunogenetics by requiring the interpretation of gene mapping and association study results within the strict confines of ABHI certification requirements. The challenge lies in discerning which approach to analyzing such data aligns with the established regulatory framework and best practices for clinical application, ensuring patient safety and data integrity. Careful judgment is required to differentiate between scientifically sound methodologies and those that may not meet the rigorous standards for clinical decision-making in transplantation. The correct approach represents best professional practice because it prioritizes the validation and replication of findings, a cornerstone of scientific rigor and regulatory compliance in clinical genetics. By focusing on studies that have undergone peer review and demonstrated consistent results across diverse populations, it ensures that the gene mapping and association data are reliable and applicable to the patient population served by a histocompatibility laboratory. This aligns with the ABHI mandate to uphold high standards of practice, which implicitly requires the use of evidence-based information that has been thoroughly vetted. The emphasis on established databases and consensus reports further reinforces the commitment to using validated information, minimizing the risk of misinterpretation or misapplication of genetic data in patient care. An incorrect approach that relies solely on preliminary or unpublished data is professionally unacceptable due to the inherent risk of using unverified information. This violates the ethical principle of beneficence, as it could lead to incorrect clinical decisions based on potentially flawed findings. From a regulatory perspective, it fails to adhere to the expectation of using validated diagnostic and prognostic tools, which are typically derived from peer-reviewed and replicated research. Another incorrect approach that focuses on novel but unvalidated association studies, without robust replication or independent verification, is also professionally problematic. While innovation is important, in a clinical setting governed by certification standards, the immediate application of unproven associations can compromise patient care and introduce uncertainty into transplant decisions. This approach may not meet the ABHI implicit requirement for evidence-based practice, which necessitates a higher threshold of proof before clinical adoption. A third incorrect approach that prioritizes studies with statistically significant findings, but lacks consideration for biological plausibility or clinical relevance, is also professionally unsound. Statistical significance alone does not guarantee clinical utility or accuracy in a complex biological system like the human immune response. This approach risks overemphasizing correlations that may not reflect true causal relationships or have practical implications for patient management, potentially leading to unnecessary interventions or misinterpretations of risk. The professional reasoning process for similar situations should involve a systematic evaluation of available research. This includes assessing the quality of the study design, the size and diversity of the study population, the reproducibility of the findings, and the alignment with existing biological knowledge. Professionals must critically appraise the evidence, considering its relevance to the specific clinical context and its adherence to established guidelines and best practices, as expected by the ABHI certification. The decision-making process should always prioritize patient safety and the integrity of clinical data, ensuring that all interpretations and applications of gene mapping and association studies are grounded in robust, validated scientific evidence. Question 12. The audit findings indicate that technologist consistently reports weak positive reactions in HLA antibody screening assays without performing confirmatory testing or utilizing an alternative validated method when the initial result is borderline. This practice has been noted across multiple patient samples over the past quarter. Option A. Retest the sample using a different, validated serological method or a solid-phase immunoassay if available and appropriate for the clinical question to confirm the presence of clinically significant antibodies. Option B. Disregard the weak positive reaction as likely due to technical variability or background noise and report a negative result. Option C. Document the weak positive reaction and proceed with clinical management based on the initial finding, assuming it represents a true positive. Option D. Immediately initiate desensitization protocols for the patient based on the unconfirmed weak positive antibody screen. The correct answer is A. Retest the sample using a different, validated serological method or a solid-phase immunoassay if available and appropriate for the clinical question to confirm the presence of clinically significant antibodies. Explanation. The audit findings indicate a potential deviation in the serological methods used for HLA antibody identification, specifically concerning the interpretation of weak positive reactions. This scenario is professionally challenging because accurate interpretation of serological data is fundamental to patient care in transplantation and transfusion medicine. Misinterpretation can lead to inappropriate treatment decisions, such as the selection of incompatible grafts or the administration of unnecessary therapies, directly impacting patient outcomes and safety. The ABHI certification emphasizes the critical need for meticulous adherence to established protocols and the ability to discern clinically significant results from background noise or technical artifacts. The correct approach, which involves retesting the sample using a validated alternative serological method or a more sensitive technique like solid-phase immunoassay, SPI, if available and appropriate for the clinical question, represents best professional practice. This is justified by the ABHI commitment to ensuring competency in advanced laboratory techniques and the principle of diagnostic accuracy. Regulatory frameworks, such as those overseen by the College of American Pathologists, CAP, and the Food and Drug Administration, FDA, in the U.S., mandate that laboratories employ validated methods and ensure the accuracy and reliability of their test results. Retesting with an alternative method provides a crucial layer of verification, minimizing the risk of false positives or negatives, and ensuring that clinical decisions are based on robust data. This aligns with the ethical obligation to provide competent and safe patient care. An incorrect approach would be to rely solely on the initial weak positive result without further investigation. This fails to meet the standard of care and the regulatory expectation for confirmatory testing when results are equivocal or potentially misleading. Ethically, it represents a failure to exercise due diligence and a disregard for patient safety. Another incorrect approach would be to dismiss the weak positive result entirely without any attempt at verification. This is equally problematic as it risks overlooking a clinically relevant antibody, potentially leading to a poor transplant outcome. This demonstrates a lack of critical thinking and a failure to adhere to the principles of laboratory quality assurance. A third incorrect approach might be to immediately proceed with a treatment decision based on the unconfirmed weak positive result. This is a direct violation of best practices and regulatory requirements, as it bypasses essential validation steps and exposes the patient to significant risk. Professionals should employ a decision-making framework that prioritizes patient safety and diagnostic accuracy. This involves a systematic approach. First, critically evaluate the initial result in the context of the patient's clinical history and other laboratory data. Second, if the result is equivocal or unexpected, consult established laboratory protocols for troubleshooting and re-verification. Third, if retesting is indicated, select a validated alternative method that is appropriate for the clinical scenario. And finally, document all steps taken and the rationale for the final interpretation. This iterative process ensures that all potential sources of error are addressed and that the final result is reliable. Question 13. The performance metrics show a significant discrepancy between serological and molecular typing results for a potential kidney transplant recipient's HLA locus. The serological typing suggests the presence of HLA*02, 01 and HLA*24, 02, while the molecular typing indicates HLA*02, 01 and a different, less common allele at the other locus. What is the most appropriate immediate course of action for the histocompatibility laboratory? Option A. Report the molecular typing results as definitive, assuming the serological typing may have been affected by a rare antibody or technical artifact. Option B. Proceed with the serological typing results, as they are generally considered the primary method for initial screening in many transplant centers. Option C. Initiate a comprehensive investigation involving retesting with orthogonal methods, thorough review of all laboratory documentation, and consultation with senior technologists to resolve the discrepancy before reporting final results. Option D. Immediately contact the transplant physician to inform them of the discrepancy and await their directive on how to proceed, without further internal investigation. The correct answer is C. Initiate a comprehensive investigation involving retesting with orthogonal methods, thorough review of all laboratory documentation, and consultation with senior technologists to resolve the discrepancy before reporting final results. Explanation. Scenario analysis. This scenario presents a common challenge in histocompatibility laboratories. Interpreting serological and molecular typing results in the context of potential discrepancies that could impact patient care, specifically transplant outcomes. The professional challenge lies in accurately identifying the source of the discrepancy, which could stem from technical errors, biological variations, or misinterpretation of complex genetic data. Failure to resolve such discrepancies can lead to the selection of an incompatible donor, resulting in graft rejection or other adverse events, directly contravening the ABHI commitment to patient safety and accurate HLA typing. Correct approach analysis. The correct approach involves a systematic, multifaceted investigation that prioritizes patient safety and adherence to established laboratory protocols and ABHI guidelines. This includes retesting using orthogonal methods, e.g., if serology is discordant, confirm with molecular typing, and vice versa, reviewing all associated documentation for potential clerical errors, and consulting with experienced laboratory personnel or supervisors. This methodical approach ensures that all potential sources of error are considered and addressed, leading to the most accurate and reliable HLA typing result. This aligns with the ABHI emphasis on proficiency, accuracy, and the ethical responsibility to provide high-quality diagnostic services that support optimal patient outcomes in transplantation. Incorrect approaches analysis. Proceeding with the initial typing results without further investigation, despite a significant discrepancy, represents a failure to uphold the standard of care and ABHI expectations for accuracy. This approach risks reporting erroneous data, which could lead to a mismatched transplant. Relying solely on one typing methodology, e.g., only serology, when a discrepancy arises without attempting to confirm with an alternative method, is also professionally unacceptable. This ignores the inherent limitations of any single assay and fails to provide the necessary level of assurance for critical transplant decisions. It demonstrates a lack of critical thinking and a disregard for the principle of confirmatory testing. Attributing the discrepancy solely to a rare HLA allele without a thorough investigation of more common sources of error, such as technical issues or clerical mistakes, is premature and potentially misleading. While rare alleles exist, a systematic approach must first rule out more probable causes before considering less common explanations. This approach bypasses essential quality control steps. Professional reasoning. Professionals in histocompatibility laboratories must employ a decision-making framework that prioritizes accuracy, patient safety, and regulatory compliance. This framework involves 1. Recognizing and documenting discrepancies. 2. Initiating a systematic investigation using established protocols, including retesting and review of all relevant data. 3. Consulting with colleagues and supervisors when necessary. 4. Documenting all steps taken and the final resolution. 5. Ensuring that all actions are consistent with ABHI standards and relevant laboratory regulations. This iterative process of investigation, verification, and documentation is crucial for maintaining the integrity of HLA typing and ensuring optimal patient outcomes. Question 14. Which approach would be most appropriate for a histocompatibility and immunogenetics laboratory, considering the integration of novel CAR T-cell genetic engineering techniques into their immunotherapy workflow, ensuring compliance with ABHI certification standards and U.S. regulatory guidelines? Option A. Adopting the CAR T-cell engineering process immediately based on promising preliminary research findings, with post-implementation data collection for future regulatory submissions. Option B. proceeding with the CART cell engineering process using a modified protocol from a different research institution without seeking specific regulatory guidance or conducting independent validation. Option C. Implementing the CART cell engineering process after a comprehensive review of peer-reviewed literature and internal validation studies, followed by submission for regulatory approval and adherence to all GMP/GLP requirements. Option D. Utilizing a commercially available CART cell therapy kit without independent validation, assuming its inherent safety and efficacy due to its market availability. The correct answer is C. Implementing the CART cell engineering process after a comprehensive review of peer-reviewed literature and internal validation studies, followed by submission for regulatory approval and adherence to all GMP/GLP requirements. Explanation: this scenario presents a professional challenge due to the rapid advancement of genetic engineering in immunotherapy, requiring histocompatibility and immunogenetics professionals to stay abreast of evolving technologies and their ethical implications within the strict regulatory framework of the American Board of Histocompatibility and Immunogenetics, ABHI certification. The core of the challenge lies in balancing innovation with patient safety, data integrity, and regulatory compliance. The correct approach represents best professional practice because it prioritizes a thorough understanding of the scientific underpinnings and regulatory landscape before implementing novel genetic engineering techniques in immunotherapy. This involves rigorous validation of the engineered cells, meticulous adherence to good laboratory practices, GLP, and good manufacturing practices, GMP, as mandated by relevant U.S. regulatory bodies, e.g., FDA guidelines for cellular therapies, and comprehensive risk assessment. It ensures that any therapeutic intervention is not only scientifically sound, but also safe, effective, and compliant with established standards for clinical application, thereby upholding the ABHI commitment to excellence in the field. An incorrect approach that bypasses established validation protocols and regulatory review before clinical application poses significant ethical and regulatory failures. It risks patient harm due to unforeseen immunogenicity or off-target effects of the engineered cells, violating the principle of do no harm. Furthermore, it disregards the regulatory requirement for demonstrating safety and efficacy through validated methods, potentially leading to the use of unapproved or inadequately characterized therapies. Another incorrect approach that relies solely on anecdotal evidence or preliminary research without robust clinical trial data and regulatory oversight fails to meet the evidence-based standards of medical practice and ABHI certification requirements. This can lead to premature adoption of unproven therapies, misallocation of resources, and erosion of public trust. The professional decision-making process for similar situations should involve a systematic evaluation of new technologies. This includes consulting current ABHI guidelines, relevant FDA regulations for cellular and gene therapies, and peer-reviewed scientific literature. Professionals must engage in continuous learning, participate in continuing education, and collaborate with regulatory experts and ethicists. A critical step is to assess the technology's readiness for clinical translation, considering its validation status, manufacturing scalability, and potential for adverse events, all within the established U.S. regulatory framework. Question 15. The review process indicates a discrepancy between the initial HLA typing results obtained via next-generation sequencing, NGS, and a previously performed low-resolution typing for a potential deceased donor. The technologist performing the review is confident in the NGS methodology, but notes a significant allele mismatch at a critical locus that was previously considered a strong match. The technologist is aware that the transplant recipient's transplant team is awaiting these results for immediate allocation. What is the most appropriate immediate course of action for the technologist? Option A. Report the initial NGS typing results as obtained, noting the discrepancy with the prior low-resolution typing in the report comments. Option B. Withhold all typing results until a definitive explanation for the discrepancy can be found, even if it means delaying the transplant allocation. Option C. Inform the transplant team of the discrepancy and ask them to proceed with allocation based on the prior low-resolution typing while the NGS results are investigated. Option D. Immediately rerun the NGS typing on a fresh aliquot of the donor sample, ensuring all reagents and equipment are verified according to SOPs, and consult with the laboratory director regarding the discrepancy. The correct answer is D. Immediately rerun the NGS typing on a fresh aliquot of the donor sample, ensuring all reagents and equipment are verified according to SOPs, and consult with the laboratory director regarding the discrepancy. Explanation. This scenario presents a professional challenge due to the potential for misinterpretation of molecular typing data, which has direct implications for patient care and transplant eligibility. The ethical dilemma arises from the responsibility to ensure data integrity and accurate reporting, especially when faced with a discrepancy that could impact a critical medical decision. Careful judgment is required to balance the urgency of transplant decisions with the need for absolute accuracy in laboratory results. The correct approach represents best professional practice because it prioritizes patient safety and adherence to established laboratory quality control and assurance protocols. By initiating a thorough investigation into the discrepancy, the technologist upholds the principles of accuracy and reliability mandated by professional standards and regulatory bodies governing histocompatibility laboratories. This systematic approach ensures that any potential errors are identified and corrected before results are released, preventing misallocation of organs or inappropriate treatment decisions. This aligns with the ABHI commitment to maintaining high standards of competence and ethical conduct in the field of histocompatibility. An incorrect approach that involves immediately reporting the initial result without further investigation fails to uphold the fundamental ethical and professional obligation to ensure data accuracy. This could lead to serious patient harm if the initial typing was indeed erroneous. It bypasses critical quality control steps and demonstrates a disregard for the potential consequences of inaccurate reporting, violating principles of professional responsibility and potentially contravening laboratory accreditation standards. Another incorrect approach, that of withholding all results indefinitely until absolute certainty is achieved, while well-intentioned, can also be professionally problematic. Accuracy is paramount. Transplant decisions often operate under time-sensitive constraints. An indefinite hold without a clear plan for resolution can delay critical patient care and negatively impact transplant outcomes. This approach lacks a structured problem-solving methodology and can lead to inefficiencies within the laboratory and the transplant program. A further incorrect approach, which is to rely solely on the opinion of a single, more experienced colleague without independent verification or adherence to established protocols, is also professionally unsound. While collegial consultation is valuable, it should supplement, not replace, rigorous quality control procedures. Over-reliance on individual expertise without a systematic investigation risks perpetuating potential errors if the colleague's assessment is also flawed or incomplete. It undermines the standardized processes designed to ensure consistent and reliable results across all personnel. Professional reasoning process for such situations should involve a clear step-by-step approach. 1. Recognize and document the discrepancy. 2. Consult established laboratory standard operating procedures, SOP, for handling such issues. 3. Initiate the defined quality control and investigation protocols, which may include rerunning samples, reviewing raw data, or performing confirmatory testing. 4. Document all steps taken and findings. 5. Consult with supervisors or designated quality assurance personnel as per SOPs. 6. Only release results after the discrepancy is resolved and validated according to established protocols. This systematic approach ensures accountability, transparency, and the highest level of accuracy in reporting. Question 16. The analysis reveals that a patient's HLA typing results show a specific allele associated with an increased risk for a particular autoimmune disease. The laboratory director is considering how to best communicate this finding to the referring physician, balancing the scientific implications with the need for responsible interpretation. Which of the following approaches best reflects the professional and regulatory expectations for a histocompatibility laboratory in this situation? Option A. Provide a detailed report to the referring physician outlining the specific HLA allele, its known association with the autoimmune disease based on current scientific literature, and a disclaimer that genetic predisposition is one factor among many contributing to disease development. Option B. Report the HLA allele and its association with the disease, but omit any mention of the multifactorial nature of disease development or the limitations of genetic prediction. Option C. Directly provide the patient with the raw HLA typing data and a list of all diseases for which their identified alleles have been associated, without physician or genetic counselor consultation. Option D. Inform the referring physician that the presence of this HLA allele definitively indicates the patient will develop the autoimmune disease, recommending immediate prophylactic treatment. The correct answer is A. Provide a detailed report to the referring physician outlining the specific HLA allele, its known association with the autoimmune disease based on current scientific literature, and a disclaimer that genetic predisposition is one factor among many contributing to disease development. Explanation. The analysis reveals a scenario where a histocompatibility laboratory is tasked with interpreting genetic variation data in the context of disease susceptibility for a patient. This is professionally challenging because it requires not only a deep understanding of HLA genetics and immunology, but also the ability to translate complex genetic information into clinically relevant insights, while adhering strictly to ABHI certification standards and U.S. regulatory frameworks governing laboratory practice and patient data. The interpretation must be accurate, ethically sound, and compliant with regulations like HIPAA, ensuring patient privacy and appropriate use of genetic information. The correct approach involves a comprehensive review of the patient's genetic profile, cross-referencing identified variations with established scientific literature and databases that link specific HLA alleles or haplotypes to known disease susceptibilities. This approach prioritizes evidence-based interpretation and aligns with the ABHI emphasis on accurate and reliable testing. It necessitates a thorough understanding of the limitations of current knowledge and the ability to communicate findings clearly and cautiously to the referring physician, emphasizing that genetic predisposition is not deterministic. This aligns with best professional practice by ensuring that the interpretation is grounded in scientific validity and clinical utility, while respecting the patient's autonomy and the physician's role in patient management. An incorrect approach would be to overstate the predictive power of identified genetic variations without sufficient scientific backing. This could lead to misinformed clinical decisions, unnecessary patient anxiety, or a false sense of security. Ethically, this violates the principle of beneficence and non-maleficence by potentially causing harm through inaccurate or misleading information. From a regulatory standpoint, such an approach could be seen as providing a diagnostic interpretation beyond the scope of the laboratory's validated assays, or misrepresenting the clinical significance of genetic findings, potentially contravening CLIA regulations regarding laboratory test performance and reporting. Another incorrect approach would be to provide a generalized interpretation of genetic variation without considering the specific clinical context of the patient. This fails to acknowledge that disease susceptibility is multifactorial, involving environmental and lifestyle factors in addition to genetics. It also neglects the importance of personalized medicine and the need for tailored interpretations. This approach is professionally unacceptable as it lacks clinical relevance and may lead to inappropriate patient management strategies. A further incorrect approach would be to disclose genetic variation data directly to the patient without appropriate genetic counseling or physician involvement. This poses significant ethical and regulatory risks, including potential breaches of patient privacy under HIPAA and the provision of genetic information without adequate support for understanding its implications. Professional decision-making in such situations requires a systematic process. First, thoroughly understanding the request and the available data. Second, consulting relevant scientific literature and established guidelines. Third, performing a rigorous interpretation based on evidence. Fourth, clearly communicating findings and their limitations to the referring physician. And fifth, ensuring all actions comply with ABHI standards and relevant U.S. regulations. Question 17. Cost-benefit analysis shows that while allografts offer a significant therapeutic option, the long-term management of immunosuppression and potential for rejection present considerable challenges. Considering the spectrum of transplant types and their inherent immunological profiles, which approach would be most aligned with maximizing patient safety and minimizing long-term complications, assuming all necessary donor tissues are available? Option A. Proceeding with xenografts as a novel approach to overcome donor limitations, with extensive post-transplant monitoring. Option B. prioritizing autografts whenever a suitable autologous tissue source exists for the intended transplant. Option C, routinely selecting allografts for all transplant scenarios to leverage established protocols and donor registries. Option D, focusing solely on the immediate success rate of the transplant procedure, irrespective of graft type or long-term implications. The correct answer is B, prioritizing autografts whenever a suitable autologous tissue source exists for the intended transplant. Explanation: this scenario presents a common challenge in transplant immunology, balancing the potential benefits of a transplant with the inherent risks and ethical considerations, particularly when considering different graft types. The professional challenge lies in accurately assessing the immunological compatibility, potential for rejection, and the long-term viability of the graft, all within the framework of established ABHI certification standards and ethical guidelines. Careful judgment is required to select the most appropriate transplant strategy that maximizes patient benefit while minimizing harm and adhering to regulatory requirements. The correct approach represents best professional practice because it prioritizes the use of autografts when feasible. Autografts, by definition, involve transplanting tissue from one site to another within the same individual. This eliminates the risk of immunologic rejection, as the recipient's immune system recognizes the graft as self. Consequently, autografts typically require minimal or no immunosuppressive therapy, significantly reducing the associated risks of infection, malignancy, and other adverse effects. This aligns with the principle of do no harm and the ethical imperative to use the safest and most effective treatment option available, as implicitly guided by ABHI focus on accurate and safe laboratory practices in histocompatibility and immunogenetics. An incorrect approach would be to proceed with a xenograft without exhaustive investigation and justification. Xenografts, involving transplantation between different species, present the highest risk of hyperacute, acute, and chronic rejection due to significant genetic and immunological disparities. The use of xenografts is highly experimental and carries substantial ethical and regulatory hurdles, including concerns about zoonotic disease transmission and the welfare of the donor animal. Without a clear and compelling clinical rationale, and without meeting stringent regulatory requirements for such novel therapies, this approach would be professionally unacceptable and ethically questionable. Another incorrect approach would be to indiscriminately favor allografts over autografts without considering the specific clinical context. While allografts, transplants between genetically dissimilar individuals of the same species, are cornerstone of transplantation, they necessitate careful HLA matching and lifelong immunosuppression. If an autograft is a viable and effective alternative, its use would be preferred to avoid the complexities and risks associated with allogeneic transplantation. Choosing an allograft when an autograft is equally or more suitable would represent a failure to optimize patient care and potentially expose the patient to unnecessary risks, deviating from best practices in transplant selection. The professional decision-making process for similar situations should involve a thorough evaluation of the patient's clinical condition, the availability of suitable donor tissues, and the potential risks and benefits associated with each type of graft. This includes a comprehensive understanding of the immunological principles governing graft acceptance and rejection, as well as adherence to all relevant regulatory guidelines and ethical considerations. Professionals must critically assess the evidence supporting each transplantation strategy and prioritize patient safety and well-being above all else. Question 18. System analysis indicates that a histocompatibility laboratory performing HLA typing for potential transplant recipients encounters an unexpected result where a patient's genotype appears inconsistent with their phenotype based on initial serological testing. The laboratory director needs to determine the most appropriate course of action to ensure the accuracy and reliability of the data. Which of the following represents the most appropriate initial approach? Option A, disregard the phenotypic data and rely solely on the initial genotypic typing results for reporting. Option B, manually adjust the genotypic typing results to align with the observed phenotypic data without further investigation. Option C, assume the discrepancy is due to a rare genetic anomaly in the patient and proceed with reporting the initial findings. Option D, immediately reevaluate the quality control data for the reagents and instruments used in the initial testing, and consider repeating the assay with fresh reagents if indicated. The correct answer is D. Immediately reevaluate the quality control data for the reagents and instruments used in the initial testing, and consider repeating the assay with fresh reagents if indicated. Explanation. Scenario analysis. This scenario presents a common challenge in histocompatibility testing, where a discrepancy arises between expected and observed results. The professional challenge lies in accurately identifying the source of the discrepancy while adhering to strict regulatory requirements for quality control and data integrity, ensuring patient safety and the reliability of transplant decisions. The need for meticulous investigation and documentation is paramount. Correct approach analysis. The correct approach involves a systematic, documented investigation that begins with reevaluating the initial testing process, including reagent quality, instrument calibration, and technician technique. This aligns with the principles of good laboratory practice, GLP, and the specific guidelines set forth by the American Board of Histocompatibility and Immunogenetics, ABHI, for maintaining laboratory quality and accuracy. The ABHI certification emphasizes a thorough understanding of the scientific principles and regulatory compliance necessary for accurate histocompatibility testing. Retesting with a fresh aliquot of reagents, and if necessary, repeating the entire assay under controlled conditions, are standard procedures to rule out technical errors or reagent issues. Documenting each step of the investigation is critical for regulatory compliance and for future reference. Incorrect approaches analysis. One incorrect approach involves immediately attributing the discrepancy to a patient-specific factor without a thorough investigation of potential laboratory errors. This bypasses essential quality control steps mandated by regulatory bodies and ABHI guidelines, potentially leading to incorrect transplant decisions and patient harm. It represents a failure to follow established protocols for troubleshooting and quality assurance. Another incorrect approach is to disregard the discrepancy and proceed with reporting the initial, potentially erroneous, results. This is a direct violation of GLP and ABHI standards, which require accurate and reliable data. Such an action compromises patient safety, undermines the integrity of the laboratory, and carries significant regulatory and ethical consequences. A third incorrect approach is to modify the data to fit the expected outcome without a valid scientific or technical justification. This constitutes data falsification, a severe ethical and regulatory breach that can have devastating consequences for transplant recipients and lead to severe penalties for the laboratory and its personnel. Professional reasoning. Professionals in histocompatibility and immunogenetics must approach discrepancies with a systematic, evidence-based methodology. The decision-making process should prioritize patient safety and data integrity. This involves 1. Recognizing the discrepancy and its potential impact. 2. Initiating a documented investigation following established laboratory protocols and regulatory guidelines. 3. Evaluating all potential sources of error, from reagents and equipment to technical execution. 4. Implementing corrective actions based on the investigation's findings. 5. Retesting and validating results before reporting. 6. Thoroughly documenting all steps and conclusions. This structured approach ensures compliance with ABHI standards and upholds the highest ethical principles of laboratory practice. Question 19. During the evaluation of a renal transplant recipient presenting with acute graft dysfunction 2 weeks post-transplantation, which of the following diagnostic approaches best differentiates between acute cellular rejection and antibody-mediated rejection? Option A. Interpreting the patient's overall immune status and HLA matching without specific post-transplant immunological assays. Option B. Relying exclusively on the initial pre-transplant T-cell and B-cell crossmatch results to determine the rejection mechanism. Option C. Prioritizing the assessment of donor-specific antibodies, DSA, through sensitive solid-phase assays and evaluating the presence of C4d deposition on graft biopsy. Option D. Focusing solely on the T-cell-mediated cytotoxicity in a historical mixed lymphocyte culture, MLC, performed prior to transplantation. The correct answer is C. Prioritizing the assessment of donor-specific antibodies, DSA, through sensitive solid-phase assays and evaluating the presence of C4d deposition on graft biopsy. Explanation. The scenario presents a common but complex challenge in histocompatibility and immunogenetics, differentiating between the various mechanisms of graft rejection. This requires a deep understanding of the immunological processes involved and the ability to interpret clinical and laboratory data to pinpoint the dominant rejection pathway. The professional challenge lies in accurately diagnosing the type of rejection to guide appropriate therapeutic interventions, as different rejection mechanisms necessitate distinct treatment strategies. Misdiagnosis can lead to ineffective treatment, graft loss, and patient harm. The correct approach involves a systematic evaluation of all available data, including patient history, serological testing, e.g., donor-specific antibodies, cellular assays, e.g., T-cell crossmatch, mixed lymphocyte reaction, and potentially biopsy findings, to identify the primary immunological effector mechanism. This aligns with the ABHI certification's emphasis on comprehensive knowledge and application of immunogenetic principles in clinical practice. Best professional practice dictates a thorough, evidence-based diagnostic process that considers all potential rejection pathways, ensuring that treatment is targeted and effective, thereby upholding the highest standards of patient care and professional competence as expected by the ABHI. An incorrect approach would be to prematurely conclude the rejection mechanism based on limited or preliminary data. For instance, assuming hyperacute rejection solely based on early graft dysfunction without confirming preformed antibodies or a positive crossmatch would be a failure to adhere to established diagnostic protocols. Similarly, attributing rejection solely to a cellular mechanism without investigating humoral factors, or vice versa, represents an incomplete and potentially harmful diagnostic process. These failures stem from a lack of rigorous analytical thinking and a deviation from the comprehensive, multifaceted approach required for accurate rejection diagnosis, which is fundamental to the ABHI scope of practice. The professional decision-making process should involve a structured approach. First, gather all relevant clinical and laboratory data. Second, consider the timing of graft dysfunction in relation to transplantation. Third, evaluate the evidence for humoral antibody-mediated versus cellular T-cell-mediated immunity. Fourth, integrate all findings to determine the most likely primary rejection mechanism. And finally, correlate this diagnosis with appropriate therapeutic interventions, continuously reassessing the patient's response. This systematic process ensures that diagnostic and therapeutic decisions are grounded in sound scientific principles and best practices, as expected of certified professionals. Question 20. Market research demonstrates that laboratories performing transplant immunology testing are increasingly seeking ways to optimize workflow and reporting efficiency. Considering the stringent regulatory requirements for ABHI certification and U.S. federal laboratory regulations, which of the following approaches best ensures the integrity and accuracy of transplant immunology data interpretation while maintaining compliance? Option A. The laboratory outsources the interpretation of all complex transplant immunology data to a third-party vendor without establishing internal validation procedures or direct oversight of the vendor's interpretive process. Option B. Technologists independently interpret all transplant immunology data, relying on their experience and available literature to provide results directly to the transplant team, with minimal supervisory review. Option C. The laboratory prioritizes rapid reporting of transplant immunology results, allowing technologists to release data as soon as preliminary findings are available, with a commitment to correcting any errors retrospectively. Option D. The laboratory director establishes clear protocols for the interpretation of transplant immunology data, ensuring that all interpretations are performed by qualified personnel under appropriate supervision, with a robust quality assurance program in place to review and validate all critical results before reporting. The correct answer is D. The laboratory director establishes clear protocols for the interpretation of transplant immunology data, ensuring that all interpretations are performed by qualified personnel under appropriate supervision, with a robust quality assurance program in place to review and validate all critical results before reporting. Explanation. Scenario analysis. This scenario presents a professional challenge in a transplant immunology laboratory operating under the strict regulatory framework of the American Board of Histocompatibility and Immunogenetics, ABHI certification. The challenge lies in ensuring that laboratory practices, particularly those involving the interpretation of transplant immunology data for patient care, strictly adhere to ABHI guidelines and relevant U.S. federal regulations, e.g., CLIA. The potential for patient harm due to misinterpretation or noncompliance is significant, necessitating meticulous attention to detail and a thorough understanding of the regulatory landscape. Correct approach analysis. The correct approach emphasizes the critical role of the laboratory director in overseeing all aspects of laboratory operations, including the interpretation of transplant immunology data. This aligns with ABHI certification requirements and CLIA regulations, which mandate that a qualified laboratory director is responsible for the technical and scientific operations of the laboratory, including the establishment and maintenance of quality systems. The director's responsibility extends to ensuring that all personnel are qualified and that policies and procedures are in place to guarantee accurate and reliable test results, which are paramount in transplant immunology, where patient outcomes are directly impacted. This approach upholds the highest standards of patient safety and regulatory compliance. Incorrect approaches analysis. One incorrect approach involves delegating the final interpretation of complex transplant immunology data solely to technologists without direct oversight from a qualified director or supervisor. This violates ABHI and CLIA requirements for supervisory review and technical competence, potentially leading to misinterpretation and adverse patient events. It bypasses the established quality control mechanisms designed to ensure accuracy. Another incorrect approach is to rely on external, unvalidated interpretation services for critical transplant immunology data without a robust internal validation process and clear lines of accountability. This introduces an unacceptable level of risk, as the laboratory cannot guarantee the quality or regulatory compliance of the external service, nor can it ensure that the interpretation meets the specific needs and standards of the patient population served. This approach fails to meet the laboratory's responsibility for accurate and reliable testing. A third incorrect approach is to prioritize speed of reporting over the thoroughness of data interpretation and quality control checks. In transplant immunology, the nuances of antibody identification, HLA matching, and cross-match results require careful, deliberate analysis. Expediting this process without adhering to established protocols and supervisory review can lead to errors, compromising patient safety and violating regulatory mandates for quality assurance. Professional reasoning. Professionals in ABHI-certified laboratories must adopt a decision-making process that prioritizes patient safety and regulatory compliance above all else. This involves a deep understanding of the ABHI certification standards and applicable U.S. federal regulations. When faced with complex interpretive challenges, the process should involve 1. Adherence to established, validated laboratory protocols. 2. Consultation with qualified supervisors and the laboratory director for complex or ambiguous results. 3. Thorough documentation of all interpretive steps and decisions. 4. Continuous quality improvement initiatives to identify and address potential areas of non-compliance or error. The ultimate goal is to ensure that all laboratory data directly contributes to safe and effective patient care within the defined regulatory framework.